Am I sharing properly?
Yes, it's great.
Thanks. So for today, Bojosi and I would like to talk briefly around our roles as occupational hygienists in healthcare during the COVID pandemic. So a little bit about our healthcare organization, Fraser Health. We have 12 acute care hospitals and we have over 7,000 long-term care beds. Our health delivery area covers from Burnaby all the way to Fraser Canyon and all the way south to Delta and White Chalk. So our health organization is composed of over 40,000 staff, medical staff, and volunteers. So for the health and safety team of our health authority, we have a group of experts with different focuses and different backgrounds. Currently, we have 6 occupational hygienists for the team. So the focus of my talk today, I would like to talk about some of the contingency and crisis measures we introduced since the start of the pandemic to flatten the curve of PPE consumption and to optimize PPE supply. Because for a long period into the pandemic, one great risk posed on the healthcare worker is the shortage of PPE supply. So I'm going to introduce our first contingency measure, which is the use of the respirators beyond the shelf life. So since the start of the pandemic, we received a lot of the expired respirators from the federal pandemic stock. So to take one respirator model, the 3M 1870 as an example, I'd like to show you our considerations to determine whether the expired respirators should be deployed or not. So very importantly, we start with the filtration efficiency. We want to make sure that it still meets with the expired stock, still meets with the 95% filtration efficiency. So that has been verified by the NIOSH National Personal Protective Technology Lab project, and is way over 95%. Another factor we considered is whether the fitting characteristics are maintained by the expired respirators. So NIOSH also did some study as represented by the green bar. The expired to loss while being fit tested by subjects selected from the NIOSH bivariate fit panel, there's no reduction in the overall fit factor. Also, the NIOSH study evaluated the strap extension stiffness, and there's really no reduction in that as well. Another consideration is whether it is regulated, this practice is regulated by the local authority or not. So we verified this from the CDC, Occupational Health and Safety Guideline. Also, in terms of the actual planning for the deployment, we focus a lot on communicating to staff members around the upcoming expired respirators and train them how to do an even more thorough job for PPE inspection before donning. So another contingency strategy we introduced is to use respirators for multiple patient encounter. So by comparison, before the pandemic, the common practice is that the healthcare worker will be put on one respirator to see one patient and then take off and put on a new one for the next patient. But during PPE shortages, we cannot sustain this practice. So, which is why in consultation with infection prevention and control specialists, we issued this change of practice. So in our communication, we're really clear that extended use of respirators does not equal to reusing the respirators without decontamination, because we are also concerned with fomite contamination on the surface of the respirators. We did not allow the double masking, which means apply a mask on top of the respirator for extended usage. That's because the primary concern is that the fit might be compromised, especially for respirators which has a flat fold style or a duckbill style. Those are very prone to compromise fit. Okay, so I want to talk briefly around the other engineering controls we have in healthcare, especially the ventilation. So for healthcare facilities, we're governed by the CSA Z317.2, which sets ventilation rate for healthcare facilities in the unit of air change per hour. And this might be different for the cubic feet per minute per occupant, which you might see in the ASHRAE 60.1 standards for commercial buildings. And in general, the healthcare ventilation rate requirement is much higher. For instance, for airborne isolation room, where we have patients who are critically ill and they might be going through ventilation or even intubation, we're looking at 12 total air change per hour. Also for regular patient rooms in hospitals is 6, and for long-term care it is 4. Unfortunately, even with this enhanced ventilation, it does not negate the requirement of using respiratory protection for clinical staff members, because those are general dilute ventilation, they're not local exhaust. However, the air clearance table using the simple dilution model might be used for some non-clinical or supporting staff member, for instance, environmental service staff member who need to do a terminal clean after the patient being discharged. They can, in developing their SOP, we can use the air clearance table to make sure that we utilize ventilation as much as possible to clear out over 99% of the airborne contaminants before safe entry to that previously contaminated space. Also, another measure is the introduction of commercial respirators into healthcare. So this table shows the difference between the performance of healthcare or surgical respirator versus industrial or commercial respirator. As you can see, in terms of the filtration efficiency for particles in the MPPS range, or the maximum penetrating particle size, there's really no difference. And through the same testing method by NIOSH. The only difference for surgical respirator lies in the blood and bodily fluid splash resistance, which is a feature designed for operating room or trauma patient care. Another difference is the bacterial filtration efficiency, but for respirators which pass the very stringent NIOSH and N95 testing, there's no issue with them there's no concern for them to not meeting with the bacterial filtration requirements. Also, in terms of design, you might see the respirators with exhalation valve for commercial respirators, but that's not allowed for surgical respirators. So we did lots of communication to staff member to ease their concern and to recommend them to use commercial N95 respirator if there's a fit. So I just checked our record. Currently, we are over 10 months into the normal PPE supply, but still we have 6% of our healthcare workers who still choose to use commercial grade N95 in their annual fit testing refreshments. Okay. So I'd like to introduce the first poll question I have, because in the States, they introduced, they are distributing the commercial grade N95 respirators to the general public as the groceries of the pharmacy. And there was some debate over the social media around whether the commercial grade respirator is good for COVID or not. So I think I'd like to learn your opinion around whether do you think filtering face-piece respirators should be distributed to the public? Okay. I'm going to share the result. So I think the majority said no to this question. So that's interesting to know your thoughts. Okay, so I'm going to Okay. So continue to the next contingency strategy we used, which is to expand use of elastomeric half-face respirators clinical staff. So before the pandemic, mainly the EHFR are used by staff members who are seeking for protection against chemical particulates and chemical gases or vapors. And during the PPE shortage, we expanded the scope of its use to cover the clinical staff member. And as occupational hygienists, we were greatly involved in developing SOPs for the proper inspection and cleaning and disinfection of the EHFRs. So to evaluate, it turned out to be one of the most effective means to reduce the disposable respirator consumption. So by looking at the data from the intensive care unit of Surrey Memorial Hospital, which is our flagship hospital, over 82% of our staff members chose to be fit tested with both EHFR and disposable face-piece respirator. And that resulted in almost 70% reduction in annual disposable respirator usage. And our plan is to keep EHFR as one option for our staff members, because some staff members, they do feel, they do prefer to use EHFR. So I'd like to have your opinion on the source control concern for valved respirators. So for those of you who might not be familiar with the concept, source control means if I'm using the valved respirator, my expelled air, my exhaled air might be released to the environment without being filtered. So that might pose a theoretic risk to people surrounding me. So do you think that would be of concern? Okay, perfect. From the poll result, I can see that over 80% deemed it indeed is of concern. So I would like to show one NIOSH study which evaluated the filtration efficiency of filtering face pieces with valved exhalation valve. So the picture on the left-hand side is a standard N95 filtration testing setup. And the NIOSH researcher, they creatively reversed the position of the N95 respirator to demonstrate the particular filtration as a simulation of source control. And their finding is that disposable, the face piece respirators with exhalation valve itself provides source control similar or better than the medical or surgical mask. And they recommended that covering the exhalation valve from inside with surgical tape or ECG pad further enhanced the source control efficiency. It may bring up the level to the same level as respirators without any exhalation valve. Okay, unfortunately, there's really no study on the source control efficiency for EHFR and PAPR. So my suggestion to the occupational hygienists on the field is that first we need to determine whether the source control is an issue or not. So for healthcare, for instance, if the healthcare worker in the ICU patient room, they are all wearing EHFR and their patient is positive with COVID, then I wouldn't say that we need to concern with source control. However, source control might be an issue maybe for a medical clinic where the healthcare worker is using the valve respirator, but you have the general public who might be more vulnerable to the disease transmission in the waiting area. So it's really a case-by-case scenario, okay? And if you are really concerned, there are engineering solutions out there. For instance, 3M, they have the exhalation valve cover, which can be mounted on certain models of their EHFR. Also, there are other manufacturers who made NIOSH certified source control respirators. So basically, both the inhaled and exhaled air will be coming through the P100 filter. Okay. I also briefly want to talk about PAPRS, or powered air purifying respirators. So before the pandemic, we have been using this for hazmat situations or Ebola response. And during the pandemic, we deployed over 200 sets of PAPRS to our frontline staff member. And some staff members, they do prefer the PAPR, especially you have some air circulation around for better thermal comfort. Also, it's the option for staff member who cannot be clean shaven to use a tight fitting respirator. Okay, so I'll briefly talk about the respirator of other standards. So we are in the position, our position is that we should not really be considering respirators other than NIOSH or CSE certified because for those two types, we do have a system to verify whether it is certified by a government body or not. However, for other respirators such as K95s, which refers to a group of respirator conforms to the Chinese GB 2626 standards, there's really no government body which we can verify the authenticity. So for instance, the NIOSH NPPTL program, they evaluated some international respirators. And as you can see from this one example, the filtration efficiency is below 95%. And it's even lower than the performance of the medical or surgical masks, okay? Also, the majority of the K95, they have ear loop design. I mean, although NIOSH, they accepted very few ear loop design, but from our practice, it's very hard to get a proper fit without the fastening device. And it's in practice, it's just very difficult to standardize. Okay, and I will pass on to my colleague Bojosi.
Thank you, Phil. I'm just going to share my screen. And please let me know if you can see my screen.
Yes, I can.
Yes, okay, great, wonderful. All right, so as mentioned, my name is Bojosi Gamontle, and I am one of the exposure prevention specialists with Fraser Health. So, so basically my portfolio covers these things that you see, but first and foremost, what I wanted to mention was that during the pandemic, as many organizations did, our department also had a team that focused specifically on answering questions or inquiries from leaders from the hospitals that are specific to COVID-19. And so Phil and myself and two other occupational hygienists and our team leader and one of our support team members formed this pandemic team. But primarily, my portfolio, I focus on communicable diseases, the exposure control program, and you see on the right here, that's the manual, table of contents of the manual that we use for the communicable disease ECP. And so basically, I do annual review of this program and make sure that all 9 models that we provide for healthcare workers to learn from are updated. And I also do research and evaluation. And we currently have several projects that are ongoing that are specific for respirators, as you can see there. But for today's presentation, I'm going to be focusing on blood and body fluids exposure, specifically eye splash exposures. And the reason why that is of interest is that, as Phil talked about respirators, for respirators, we have standards and we have procedures that if a healthcare worker is going to use a respirator, they have to be fit tested first, whether it's a qualitative fit testing or a quantitative fit test. Now, when it comes to eye and protection, eye and facial protection, we don't necessarily have those standards within healthcare. And so, okay, so we don't have those standards. So here's my question. The poll question for do you think that there's a universal standard for eye and facial protection for biological hazards? Okay, so 19% said true, and majority of everyone said it is false. Now, I want to share with you a context around standards before I get to the response to this question. So there are several eye and facial protection standards that are currently in use. One of them being the Occupational Safety and Health Administration, the OSHA standard 1910-1030, that focuses on blood-borne pathogens. But if you look at the standard, it only has a single sentence that talks about masks and eye protection. So it doesn't really go in depth into eye and facial protection. We also have the ANSI, the Z87.1. It also talks about eye and facial protection, but it focuses on fields outside the healthcare industry. So it talks about machinery operations and chemical exposures. And then we have the Canadian Standards Association, which is what we normally use here at home, as well as the ANSI. We apply that to exposures that we work with. Even though the ANSI standard, the CSA standard talks about this particular standard, which was actually promulgated 2 years ago, that it applies to all occupational and educational operations, it doesn't necessarily talk about biological hazards. And for those who might, be asking when we talk about eye and facial protection, what exactly are we referring to? So if you see at the bottom of the screen here, when we talk about eye and facial protection, we're talking about the face shield, the goggles, and the facial mask, either mask or respirator, depending on what the healthcare worker is using at the time. Now, here's the answer to that question. So if you said that it's true that there is no standard, you would be forgiven for saying so. If you said there is a standard, there is actually a standard that is very, very recent. The standard was promulgated in July of last year. So it's actually very new, and I wouldn't be surprised if most of us in the field actually don't know that it's there. But there is a standard, and it's new. But in light of the standard that the standards that for eye and facial protection that wasn't there for a long time, last year a couple of occupational hygienists from different health authorities came together, formed a provincial working group to come up with a selection tool that can be used by healthcare workers in selecting eye and facial protection. Now, you would recognize the awesome models in the pictures as your presenters today. So we came up with this eye protection selection tool to help healthcare workers when they are selecting eye and facial protection, to select eye and facial protection that fits them and that can potentially protect them from hazards, from biological hazards and other hazards that they encounter in the workplace. Now, you'll see that one of the things that we recommended was that the safety glasses or goggles have to be provide coverage from the eyebrows to at least the cheekbones, and that the side of the glasses should provide coverage from the nose to the temple. And we also, and that was the same for prescription safety goggles. And for those who are wearing goggles, we recommended that the strap should be adjusted in a way that it fits snugly on the face to ensure that there are no gaps between goggles and the face. And this selection tool has since been released to the health authorities and to the healthcare workers to assist them in selecting eye and facial protection that actually fits and potentially protects them. So next, I wanted to talk about a review that we're currently working on. Oh. Okay, how do I go back here? A review that we're currently, I'll leave it here. A review that we're currently working on on blood and body fluids, specifically eye splash exposures. And I wanted to preface that by saying that before COVID-19, eye and facial protection for Fraser Health, at least, was a requirement. It was required that healthcare workers would put on eye and facial protection when they're providing care to patients. However, there was a point of care risk assessment that healthcare workers could determine if they're going to be potentially exposed to splashes or sprays or body and blood fluids, that they would select to wear eye and protection. And if that were not the case, they would not necessarily have to do so. Now, during the pandemic, it became a requirement for all healthcare workers to wear or to don and doff eye and facial protection. And so all healthcare settings, in the acute care settings, healthcare workers were required to wear eye and facial protection. As you can see, that first sentence that's highlighted, that eye and protection is supposed to be worn at the beginning of the shift until the end of the shift. And this still applies in emergency rooms and operating rooms and non-clinical departments. Now, because of this, we wanted to know, is there any difference in the way that healthcare workers wear eye and facial protection before the mandates to wear eye and facial protection and after? And this is all during the pandemic, because the guidelines became mandatory that as a healthcare worker, you have to put on eye and facial protection when you're taking care of your patients. Now, I have to give this disclaimer that this is still very much a work in progress, that we're working on this. So we did a literature review. We reviewed some studies that have been conducted in this area. And I can safely say, which is not surprising, given that if you look at the standards for healthcare, for eye and facial protection, they were not promulgated until this past year. So there really isn't a lot of research that has been done in this area for eye and facial splash exposures. So we came across studies that focused on the efficacy of face shields, or that looked at eye protection and N95 and respirators in conjunction, wearing everything together. So I wanted to share this study with you, just to give you an idea of some of the things that we also wanted to look at. So this study came out of Southern India, and it's a study that was the principal investigator of the study was actually an ophthalmologist, which is, I guess that makes sense. And so they went into this hospital in Southern India that has over 11,000 healthcare workers, and they wanted to see, they had collected data from healthcare workers who experienced eye splashes or infection or foreign bodies into the eye, or they got splashed or sprayed with body and body fluids for a period of 6 months. And so out of the 11,000, 94 participants in that time period reported to this study. And what you see there in that pie chart is some of the results from the study. And I wanted you to focus your attention on the blood and body fluids. That is 8% of those who reported to the study experienced those exposures. Now, so one of the interesting things here was that not wearing your eyeglasses was associated with a risk factor for exposure. And another thing that was found from the study that was that 44% or almost 45% of the participants were aware that PPE, eye and facial protection, was available for them, that they could have used them in provision of care. 38% reported that they had been trained in donning and doffing eye protection. However, only 28% reported that they regularly used eye and facial protection. Now, for our particular study, we used one of the reports that we have available for us at Fraser Health. And this is a reports that come in on a weekly basis to us, and we get to see from different sites within Fraser Health, from different acute hospitals, and even long-term care, the number of blood and body fluids exposures. And so this is a report that we use to do our review. And as I mentioned, this is still very much a work in progress, and I wanted to share this with you today. And these are basically counts, so they're not rates or proportions. So we can't really make any claims as to the certainty of this result at the moment, because we're still analyzing this data. But basically, we divided the data into two parts. We wanted to see the incidence from 2019 to 2020, and that is before the iron protection mandates were implemented, were put in place, and after the iron protection mandates were put into place. Now, what you see under the column that says incidents and needle stick injuries, we had those combined. The reports that we received have a combination of needle stick injuries and eye splash exposures combined. So those are blood and body fluids exposures. And so in February, in 2019 to 2020, before the mandates, we had 453 in all of Fraser Health incidents of needle stick injuries and body and blood fluids. Of those, 26% were eye splash exposures. And out of those, 7.6% reported, only 7.6% reported that they actually wore eye and facial protection in the incidents report that they recorded after having the splashes. Now, after the mandate, after the eye and facial protection were required, was required for healthcare workers from May 2020 to 2021, we had 319 body and blood and body fluids exposures, including needle stick injuries and eye splash exposures. And only 11% of those were eye splash exposures. And now you can see here that 57% of those reported that they had actually worn eye protection after the mandate. I mean, we could, obviously we still, working on the analysis for this, but going by the counts, by what we have, we can see that there's some difference there that has been, that's there. We don't know if that is because of the mandate or something else. Now, looking at here, we at the facilities, exposures, eye exposures according to facilities, you see that this is on the top left is the before the mandates, and on the bottom right is after the eye and facial protection guidelines were mandated. Now you see that hospital A here on the top had about 20 eye splash exposures reported in 2019 to 2020. And the same hospital had 2 incidents reported after the mandate. And then you also have a long-term care that is among those facilities before the mandates, and after the mandates, you actually don't see that long-term care. And then Hospital C, which had the highest incidences of eye splash exposures, had 30 incidences reported before the mandates were implemented. And then you see that same hospital, after the eye splash iron protection mandates were implemented, that there was only 7 incidences that were reported. Now, so that's where the analysis is at the moment. So to continue from this, we may compare the eye splash exposures before the mandates, during the mandates, and post COVID-19 measures if we're ever going to get there. And then also we'll calculate the rates and proportions and statistical significance, and we may also have some interviews and focus groups with our healthcare workers to get a sense of that perspective on eye and facial protection itself and the mandates and all that. And we're hoping to get some work published out of this to contribute to the studies, as I mentioned before. There really isn't a lot of studies in this area. And so in conclusion, those are some of the roles or the activities that we did, Phil and myself, as occupational hygienist and Fraser Health during the pandemic. And I think at this point, we'll open things up for questions.